availability of third molars, positioning after the extractions in class 2 subdivisions malocclusions. And asymmetric malocclusions can happen with class 2 malocclusions, class 3 malocclusions. And we start about the class 2 malocclusions, since the class 2 malocclusion is a major reason that patients seek for orthodontic treatment. Also, Silva Filho in 1990 found in his research in São Paulo that 42% of the kids who looks for treatment were class 2 malocclusions. And Sassuni in 70 found in his article that were 128 different types of class 2 malocclusions that would require 128 different strategies of treatment. So class 2 malocclusions are in our practice daily. And Johnson saw that 50% of the class 2 malocclusions were subdivision. So it's a major number that should have our attention to treat this patient. The class 2 subdivision and the class 3 subdivision are divided in type 1, type 2, and mixed. Mixed is when we have both characteristics of the type 1 and the type 2 subdivision. I'll explain a little bit about these different types. So asymmetric malocclusions happens when we have class 1 characteristics at one side and class 2 or class 3 characteristics at the other side. This will cause by a consequence a dental midline deviation. This dental midline deviation could happen in the maxillary arch or in the mandibular arch. So we have the dental midline deviation when compared with the mid-sagittal plane. The class 2 subdivision type 1 happens when our problem, happens when we have mandibular first molar more distally typed. So when we have this distal positioning of the mandibular first molar, this will cause by a consequence the class 2 malocclusion at the side and also a dental midline deviation, the mandibular dental midline deviation. So look at this case. This patient, he has a class 1 malocclusion, a class 1 at one side and the class 2 at this side, and this will cause by consequence a mandibular dental midline deviation. And the type 2, class 2 subdivision type 2 happens when we have the mandibular first molar well positioned. However, the maxillary first molar is medially. So this also will cause by a consequence a dental midline deviation. However, in the type 2, the maxillary dental midline deviation with the mid-sagittal plane. So we can see with this patient, she has a coincidence with the mandibular dental midline deviation with the mid-sagittal plane. However, because of her class 2 subdivision malocclusion, she has a maxillary dental midline deviation. So of these 50% subdivisions, the type 1 are the primarily cause. So the distal positioning of the mandibular first molar is the primarily cause of the class 2 malocclusion with 61.36%. Type 2, 18.18% has the maxillary dental midline deviation caused by the class 2 subdivision, and 20.45 are mixed. So they have a little of the distal position of the mandibular first molar and a mesial position of the maxillary first molar. We know that the class 2 malocclusion is our major concern in orthodontics problems in our practice, and the class 2 malocclusion can be treated with several strategies. And the class 2 subdivision are not different. They can be treated with removable function appliance, unilateral elastics, fixed functional appliance, also with extractions and temporary anchorage device. In this article, Dr. Johnson in 2001 researched about the three-dimensional evaluation of skeletal and dental asymmetries in class 2 subdivision malocclusions. You can have this article just scanning this QR code. And he established in his article that therefore the involvement of the mandibular dental midline will be implicit in the more distal positioning of the mandibular molars. So he's talking about the malocclusion severity. The malocclusion severity is very important to determine which approach, which strategy we use in our treatment. He also established in this article that the asymmetric malocclusions are major dental alveolar asymmetries with little skeletal involvement. So this will provide to our patient because of the overjet of 3.5 millimeters. This amount of overjet are usually compensated, camouflaged by the soft tissue. So with an overjet of 3.5 millimeters, the soft tissue compensated, giving to our patient an harmonic facial profile. So usually the patients with asymmetric malocclusions has a good facial profile and harmonic and satisfactory facial profile. So you can see in this patient, he has a good profile with a maxillary dental midline coincident with the mid-sagittal plane. However, when you look in his intraoral photographs, we can see that at his right side, he has a class 1, and at his left side, a quarter to a mild class 2 malocclusion. So this gives, by consequence, a mandibular dental midline deviation. So when we thought to treat this patient with the severity of this malocclusion, we thought about unilateral elastics, and he was a compliant patient, and he used the elastics and treat the malocclusion with a class 1 molar and canine relationship at the end of the treatment and coincident dental midlines, both maxillary and mandibular. However, in the other side, we had this patient with a class 1 at this side, and in the left side, a class 2 malocclusion. Wasn't a full class 2 malocclusion. However, he had a considerable amount of crowding, and you can see in this lateral cephalogram that he had a considerable incisors protrusion, and not considering his skeletal discrepancy. You'll see more about it later. So when we see this case, we can think about a treatment with extractions. So in the class 2 subdivision type 1, we saw that the patient, because of the distal position of the mandibular first molar, he will have a mandibular dental midline deviation. And a good strategy to treat this malocclusion with extraction would be free premolar extraction. So this free premolar extraction will provide a correction of his class 2 malocclusion and simultaneously the correction of the dental midline deviation. So that's what we thought about to Lucas. You can see in his profile that he has 12 years old, and we can think about his skeletal deficiency discrepancy right now. He knows that he is a patient that will have to do a orthogenetic surgery. However, we have to think for now a better occlusal, functional occlusion for him right now. So this is his intro photographs. He had the class 1, the class 2 crowding, and overject, and the incisors protrusion, both maxillary and mandibular protrusion, incisors protrusion. So we will extract, and if you are extracting 3 or 4 premolars. In his another study, Johnson in 2003, evaluated the class 2 subdivision treatment success rate with symmetric and asymmetric extractions protocol. So he compared the class 2 subdivision treatment with extraction of 3 and 4 premolars. We can also have this article just scanning the QR code. And what do he found? He found that when you are treating the class 2 subdivision malocclusion with extraction of 4 premolars, the patient will end with bilateral class 1 molar and canine relationships. The dental midline deviation correction will depend largely in the use of the intermaxillary elastics, so patient compliance. This will increase the treatment type because of the patient compliance in the use of intermaxillary elastics and because of the amount of retraction that will happen more with the extraction of another premolar. However, when we are treating the class 2 subdivision with the extraction of 3 premolars, the patient will end the treatment with the class 1 molar and canine relationship on the class 1 side and canine relationship on the class 2 side. Dental midlines correction will happen much more easier, since when we are retracting the space, closing the space of the extraction, you are consequently correcting the dental midline deviation. Consequence, faster treatment, and an easier orthodontic mechanics, since you have less retraction. So that's what we thought to Lucas. We bonded the fixed appliance, installed the mini screws to retraction, closing the space of the extractions, and you can see that we are aligning and leveling the incisors, and here he had almost the dental midline deviation corrected. Here with a little bit of space to close. And that's the pictures that I have of him so far. But you can see that his skeletal discrepancy 2 subdivision, class 2 subdivision. We saw that we have a maxillary dental midline deviation because of the mesial positioning of the maxillary first molars. And a good strategy to treat this type of malocclusion would be extraction of one premolar at the class 2 side. This will provide us a coincident dental midline. So you can see in this case, the patient, she has a little bit of maxillary protrusion, but satisfactory patient profile. And in her intraoral photographs, we can see that she has a full class 2 malocclusion at her right side and a class 1 on her left side with the dental midline, the maxillary dental midline deviation. And when we extract the one premolar at her class 2 side, this by the closing of the extraction space, this will provide us the correction of the canine relationship and also the dental midline deviation. In this article, they evaluated the long term of the class 2 subdivision treatment with unilateral maxillary first molar extractions. And they concluded that the unilateral maxillary first molar extraction will lead to a favorable occlusal outcomes in the long term without harming the midline aesthetics and soft tissue profile. So when comparing the treatment group to the control group, we have the black line, the pre-treatment, the red line, the post-treatment effects, and the green, the follow-up. And we can see that the soft tissue changes were minimal. The major effects were dental alveolar. So we have to consider the malocclusion severity. Not all types, not all subdivision malocclusions will treat to extraction. The malocclusion severity is very important. So this article, they treat this female patient with a mild class 2 malocclusion with Forsus fatigate resistant device. It's a good alternative to treat. And we can see that at the end of the treatment, the patient ended with class 1 molar and canine relationship. However, I can see a little bit of dental midline deviation. But it was a good satisfactory result. And at 3-year follow-up, she maintained stable. Was a good alternative to treat. She had just a mild class 2 malocclusion. We have to consider the malocclusion severity. And the class 3 subdivisions, the patients had the dental midline deviation. However, we just changed the arch of our dental midline deviation. So we have type 1 when we have a maxillary dental midline deviation, and type 2, a mandibular dental midline deviation. In this article, they showed a case report of treatment of class 3 subdivision. So you can see that the patient showed us has a little bit of protrusion of mandibular. And in her intraoral photographs, she had a class 3 subdivision malocclusion on the right side and a class 1 on the left side and a dental midline deviation, mandibular dental midline deviation. So a good strategy to treat this patient was the extraction of one premolar at the class 3 side. So when we are closing the space of the premolar extraction, this will provide the correction to the class 1 and the dental midline deviation. We can see at the end of the treatment, soft tissue, just little changes. And at the end of the treatment, she finished with canine relationship bilateral and a molar class 3 relationship on the right side. However, the studies shows us that there is no problem to finish in molar relationship of in class 2, class 3, or class 1, the patient, when we have a functional occlusion, this will lead us to a stable functional occlusion. And this other patient, he lost a premolar on his right side in a mandibular arch, and he also had a class 3 malocclusion and dental midline deviations, mandibular dental midline deviation. And a good strategy was the extraction of one premolar at his other side. To correct this dental midline deviation, the class 3 malocclusion. Using the class 3 intermaxillary elastics and simultaneously the space closing, and elastics to correct his crossbite. Closing the space. Here finishing the treatment, correcting the class 3 malocclusion, space closing. Here with class 1 canine relationships, a good overject and overbite. Here at the end of the treatment, we can see in his smile photograph that he had a dental midline coincidence, both maxillary and mandibular, to the mid-sagittal plane. His final photographs, the coincidence of the dental midline deviation. However, as I told you, not all subdivision malocclusion will treat with extraction. We have to consider one more time the malocclusion severity and the patient's needs and his wants. So this patient, he has a class 3 malocclusion. However, he doesn't want to treat with extractions, and he shows us to be a very compliant patient. So we thought to treat this type of malocclusion, this malocclusion with unilateral, with intermaxillary elastics. So after 12 months of patient excellent compliance in the use of intermaxillary elastics, we finished the treatment with the coincidence of dental midlines, both maxillary and mandibular arch, and the class 3 malocclusion, with great occlusal outcomes. You can see by the class 1 molar bilateral relationships, canine relationships, and the coincidence of the dental midlines. However, we know that patients like this will require a very good compliance and an excellent compliance, and unfortunately, these are not a reality with our patients. Most of them are not a very good compliant. His effects of the treatment, this is a pre-treatment and a post-treatment, the correction of the class 3 and the dental midline deviation. And after 2-year follow-up, we can see that the case remained stable with just, I can see just a little bit of the dental midline deviation, but the class 3 are stable. So in the treatment, we, like any other malocclusion, we have to consider the skeletal and the dental alveolar discrepancy, the malocclusion severity, the patient age, and the compliance to plan our treatment. In the asymmetric extraction protocol, we have to consider the amount of crowding, the midline deviation, and the anterior-posterior discrepancy. We saw the asymmetric extraction protocol is a simplified mechanic with less patient compliance since you correct the class 2 or the class 3 malocclusion, and this by consequent correct the dental midline deviation with a shorter treatment time. And dental skeletal and soft tissue effects. Some authors questions about the rate of stable and about the occlusal tilting, and there is already this study to prove the dental skeletal treatment changes in the class 2 subdivision malocclusion. We can also have this article just scanning the QR code, and to evaluate the class 2 subdivision treatment, they concluded that the treatment with asymmetric extractions will not cause any tilting of the occlusal plane, any extrusion of the molars, maxillary and mandibular dental midline deviation, apical discrepancies, and unfavorable skeletal changes in the frontal plane. So asymmetric protocol will treat your patient with good and satisfactory occlusal functional occlusion and smile aesthetics, and will not cause any occlusal plane tilting or extrusion or anything. So the take-home message was to give is that asymmetric extraction protocol will provide satisfactory outcomes with a simplified mechanic. However, as any other malocclusion, you have to consider the severity, the discrepancy, the amount of crowding, the compliance, the patient is very important factor to determine the treatment plan. So the asymmetric extraction is a good strategy to treat this type of malocclusion, but you will also have to consider the other factors. I want to thank you the opportunity to be here today, talking to you about this subject that I particularly found very interesting. I hope you could understand a little bit of this protocol, and these are my contacts. If you have any doubts, one more time, I want to thank you, Dr. Ajay, Dr. Henrique, Push Orthodontics, Sankarshan Patel University, Dr. Daniel, Dr. Taher. I'm very, very glad to be here. And if you have any doubts, I'm here to answer it. Thank you very much.
Can we take few questions?
Yes.
Can we take? Yeah. Okay. Great. Let me just go to the questions.
Let's just.
Okay. Status. Dr. Status is asking etiology of dental asymmetry.
What?
The first question is etiology of dental asymmetry.
I'm just trying to put the questions right here.
Yes.
Do I have access to the questions?
Yes, you do have. You do have an access.
I don't. Oh yeah, wait. Can you repeat, please, Dr. Ajay?
Pardon?
Could you repeat the question, please?
Okay. Etiology of the dental asymmetry.
I'm not listening very well.
Let me just do something here. I would.
Yeah, I'm trying to access the.
Okay, I will just type it here. Okay, let me.
Etiology of the dental asymmetry?
Yes.
Yes, okay. Primarily, the etiology of the dental asymmetry would be the distal positioning of the mandibular first molar. This is primarily factor. The secondary factor of the etiology of the dental asymmetry would be the mesial positioning of the maxillary first molar.
Right. Okay. Which article to follow this classification of class 2? Which article?
The first article of the three-dimensional. I put the QR code. I can put one more time. Let me just. This article, the three-dimensional, they explain this classification of type 1, type 2, describe about the skeletal and dental alveolar symmetries. It's a very good article to learn a little bit more about asymmetric malocclusions. This right here. Okay. This one. It's a great article. You have the file, just scanning the QR code.
Okay. The next question is, what would be the extraction pattern cases of subdivision cases which required fixed functional appliance?
Let me just find right here. Where is it?
Can you see that, Dr. Abhiraj Kher? Like in subdivision cases, right, which requires a fixed functional appliances, what would be the extraction pattern?
What would be the extraction?
Yeah, extraction pattern. Which pattern of extraction would you prefer?
No, when we are thinking about the fixed functional appliance, that's the question, right? Fixed functional appliance.
In subdivision cases. In subdivision cases.
Yes, you can use the fixed functional appliance without extracting. This will depend on the malocclusion severity, but you have to consider the incisors protrusion. So, like this patient Lucas, he already had the incisors protrusion. So this difficultates the use of fixed functional appliance. However, if you have incisors well positioned, you can think about fixed functional appliance without extracting.
Okay. There's a question, in case with the class 3 treated, like the class 3 case which you had shown with the intermaxillary elastics. So did you put any anterior bite turbo there or any bite turbos? Or only class 3 intermaxillary elastics? Dr. Jessica, are you there? I think there's a network error at her end. I think probably she must have used, she has,
yeah, Now I'm back.
Sorry.
Now I'm listening.
You can. Okay. And in the case of class 3, where you had used intermaxillary elastic, did you use
Yes.
any bite turbos?
No, this was not my case, but they didn't use.
Okay, great. Let me just go to the
You
last
don't.
question.
It's not always necessary, because we don't pass most of our day occluding. So it's not always necessary. The turbo bites usually oscillates and can give us much time. However, it's not very different to treat with turbo bites and not.
Okay. The last question, on which wire you used for retraction mechanics, and how you prevent dumping of incisors in the lower arch?
Okay. I usually do the retraction mechanics with rectangular wires. So 1825 or 1925 wire.
Okay.
I forget. Steel wire.
Okay. Okay. Thank you. Thank you so much. I think we are done with the questions. We are open for, we have a panelist. We are open for panel discussion. Now we have some eminent orthodontists from India has joined, as well as from South Africa, Dr. Mark Vardemir, and Dr. C. Chandrasekhar is the past president of Indian Orthodontic Society, and our own Dr. Rakesh Malhotra, sir. Thank you, sir, for joining in. It's a pleasure having you all here. Sir, you need to unmute yourself.
Yeah.
Okay, now you are unmuted, sir. Now you can.
Yeah, okay. So it's a pleasure to join in. And thank you, Dr. Jessica, for a wonderful lecture. Very short and sweet. And I think it sets the mind, gives the mind a lot of food for thought about asymmetric extractions. This is something normally which we do not venture into. But I think you've given a very wonderful perspective about this. And like you rightly pointed out, the most important thing is the diagnosis of the case. Whether this case will benefit from asymmetric extractions or not. And that diagnosis is very important. And at the end of it, of course, once you're able to give a good posterior occlusion, midline coinciding, upper lower in a class 1 canine relationship. And the fourth would be, of course, if you can give a good profile. So it makes sense to go in for that. Thank you so much. Wonderful to have been there.
Very honored.
Yes, Dr. Chandrasekhar, sir. I can see you are at clinic right now. So
no. I finished clinic. I just came back, and Dr. It's an excellent lecture, Dr. Jessica. It's wonderful, and to see, it's nice to see all the, especially the subdivision cases. It's always a big question mark to really how to treat this type of cases, and where there is a slight midline deviation, and but you really made things very sweet and straight, and I hope everyone has enjoyed this lecture, and I'm sure at the end of this lecture everyone will carry a good memories and something back to their, so that they can really practice in their the routine practice, and they will really get something out of this. Thank you, Dr. Jessica, and thank you very much, and sparing your time. And Ajay, of course, you are there. I am there.
Thank you, sir. Thank you, sir.
So,
Dr. G. Chandrasekhar was a past president of Indian Orthodontic Society. Now, I would, can I ask you one or two questions, Dr. Jessica, if you have your time permits?
Yes.
Right. Okay. What happens is, generally we generally don't go out of our comfort zone. as an orthodontist, we are always, comfortable staying in our comfort zone, and we don't want to do something which is out of the box. So when it comes to a question of extracting asymmetrically and moving your molars further backward or forward, and not having a molar to molar contact, right? Rather having a premolar to molar contact, right? Sometimes we become little unnerved because there might be unilateral chewing issues, or it could lead to a TMD or any other problem. Probably it might be our misconception, right? But I'm not sure how it is. So I think you have done a lot of cases, so you can just throw more light on that. That if we don't have a molar to molar contact, right? Either molar is moved too much forward with having a premolar to molar occlusal contact. Would it lead to any problem further, or would it lead to any, occlusal disturbances, TMD, or any functional issues? Have you ever encountered?
Yeah, I think that these are more risky to class 3 patients, because this molar premolar contact usually happens more with class 3 patients. We have to provide a simultaneous bilateral contacts. We have to adjust his occlusion. We have to do exams for TMD if he's a patient with any historical of any temporal joint it's functional. However, if you provide him an stable occlusal functioning with adjusted contacts, and you have to do the control of this patient, see if he presents any no caries lesion, bifraction, and you have to do the control. However, during my experience, I never saw any patient with temporal dysfunctional caused by this molar premolar contact. But we always have to do this control.
Okay, and what about the retention? Does it affect the retention in any ways?
No, the retention, here in Brazil, actually, we saw that many orthodontists are starting to use more removable retentions, like very similar to aligners.
S6.
Yes, S6. And they are trying to avoid fixed retention 3 per 3. So, but
you guys have more compliant patients, I'm sure.
Yes, because the periodontal usually influence in the hygiene, so patients are trying to use more removable retentions. However, this depends of the orthodontists.
Okay. Now we have double slot bracket specialist also here with us. So, Dr. Tahir, would you like to say anything about the asymmetrical extraction and double slots?
Well, regarding of all Jessica told, I think it was an outstanding presentation. Congratulations, Jessica. I'm very honored to be here and see colleagues of mine from Brazil making this outstanding, awesome presentation. Well, Ajay, I think bracket is a bracket like any other bracket that exists on the world. I think we have to study a little bit more with double slot bracket. I think it doesn't matter if it's an asymmetric cases or symmetric cases. I have my particular opinion. I will not say here because I'm among a lot of orthodontist experience. So as one time Mark is there and he and Mo told me, listen, we have to get a little bit more of scientific articles and studies, and we are doing that. And once we have this results, of course, we will present for you. and kind to make a better thing on orthodontics. So my only words is congratulations to all of you. Ajay, once more, you have a phenomenal guy, are doing a great job. And Jessica, congratulations. Japa, thank you so much for being here. And all my respect and regards for all of you. Thank you so much.
Thank you. Before we end this webinar, we have Dr. Celeste Nicolas from Ho Chi Minh City on Saturday, that is 15th of August, and he will be speaking on in-house aligner from diagnosis, treatment planning, production, and biomechanics. So don't miss it, guys. I have already shared the link in the chat box. Please register for that. If you're interested in doing in-house aligners, I'm sure Dr. Daniel and Dr. Enrique, probably, I don't have any conflict of interest, right? This is, we are just spreading the knowledge. I'm just joking, right? So I hope everybody would love it, because we need to see how people work. Hi, Dr. Daniel. I hope, can you just unmute yourself? Yeah, you are looking great.
Hello, everyone. Very happy to be here and very happy to listen to Dr. Jessica. And as you said, the most important thing is to spread knowledge. Like when you see cases that are out of the ordinary, makes you think outside the box or outside of the comfort zone that you're used to. So when you have different colleagues that you can discuss and then you can share ideas, no matter what bracket you use, no matter what system you use, that's the most important thing. So having this interaction between Brazil and India and having this interaction among like hundreds of colleagues is the most important thing. So that's what we think about, and that's what we know that you think about, Dr. Ajay, of spreading knowledge, sharing knowledge, and collaborating. The collaborative orthodontics and dentistry is what we need.
Thank you so much.
Thank you very much.
You know what? This was a 10th collaboration between Brazil and India, at least with the Sarkar Patel University. So we have had 10 webinars. That's a phenomenal number. Thank you. And Dr. Jessica, it was a great presentation, and some moment of time, everybody would be doing an asymmetrical extraction. Probably if not by choice, then probably by force. You don't have any other options other than doing the asymmetrical cases. And if you keep everything simple, as we have a great simplified orthodontist with us, Dr. Rakesh Malhotra, he always says that keep your things very simple and you will get the best of the results. What do you say, sir, on the concluding note?
Oh, absolutely. You know, the more simple you keep things, the better are always the results. And while technology is important to us, but we should not be servants of technology. We have to be masters of technology. And to me, I think Dr. Jessica's lecture today is another way of simplification of treating malocclusions by asymmetric extraction. Something which really simplifies the treatment and the mechanics. And I always say, please keep treatment as simple as possible. And we must respect the patient's mouth with the least intervention and with the least number of appliances we can put in the patient's mouth.
Very true.
That's always been my philosophy.
Always follow the KISS principle. Keep it simple.
Yeah, absolutely.
Yeah.
Right. Thank you so much. Thank you, everybody, for joining in.
Thank you, everybody.
A special thank to Dr. Jessica for valuable time. Again, I would say muito obrigado, if it is correct.
Obrigado. Yeah. Thank you. Okay. Nice meeting Dr. Tahir and Dr. Daniel also.
Yeah.
So, great.
Ajay,
Nice seeing you after a long time.
Ajay has become a Brazilian. He wishes everything in Brazil because he's been interacting with so many Brazil orthodontists.
No, but Ajay is
so
doing
much.
a wonderful job. I mean,
Of
this
course,
is amazing.
of course. That goes without saying.
It's amazing, that the kind of perspective we are getting from all over the world on various topics and various orthodontists. It's very good. Great, Ajay.
Thank you, sir. Thank you. Keep blessing
Thank
me.
you, Dr.
Thank
Jessica.
you. Yeah. Stay
Thank you
safe,
very
all of you.
Namaste.
Bye-bye.
Bye, Ajay.
Okay.